This meeting is being recorded.
Okay, we'll get started. Hi, everybody. Good afternoon, good morning, bonjour à tous. I'm so happy to welcome you all to this TV talk session presented by Indigenous Services Canada. Bienvenue à cette session de la série Parlons tuberculose, présentée par le Service autochtone Canada. Si vous voulez écouter en français, veuillez cliquer sur le globe terrestre en bas de votre écran et sélectionner français. My name is Charlotte Sharsky. I'm the National TV Program Coordinator at Indigenous Services Canada. I am privileged to be joining virtually today from the traditional and unceded territory of the Algonquin and Anishinaabeg people. I'm incredibly grateful for the opportunity to live on this land that is rich in history and culture, and recognizing that participants have joined from all across this country. I'd like to acknowledge the beautiful traditional lands that you each live on and are joining from today. Today's TV Talk session is about culturally responsive and safe care, and it touches on some sensitive topics such as racism and the history of TB among Indigenous peoples in Canada. These topics may bring up some difficult emotions or other reactions for some individuals, so we've included in the chat some links to various support resources and encourage you to seek that support if you need it. You will notice a pre-poll that will pop up on your screen. Thank you very much for completing it, and there will be another short poll at the end of the session. These polls just help us know who this webinar is reaching and how we may improve future events. To start this talk off in a good way and to really lay the groundwork for the presentation today, I'd like to invite Elder Verna McGregor to provide some opening remarks. Elder Verna lives in her community of Kitigan-Zibi Anishinaabeg First Nation, and she's remained grounded in Algonquin language and culture through organizing gatherings with elders and through the recent establishment of the Algonquin Culture Institute. Welcome, Elder Verna. Thank you so much for being here. And over to you.
Oh, miigwech, Charlotte. Hello, everybody. I'd like to welcome you to our unceded territory, our unceded lands, really. And for the Algonquin, we're known as Omamaninawak, which was the nomads. And we greeted a lot of the newcomers, most notably Samuel de Champlain. And so along with that history, we too experienced this issue of TB, and this became a worldwide, really epidemic. And I look forward to the speakers today in sharing their knowledge on this issue, because I mentioned at another event that if it sometimes too as well, also it was devastating with the residential school system and the children. But from that though too as well, that's where the treatment for TB also emerged from, because also too as well, we were like a control group really, and especially the children. So it's recovering from that, but also knowing too as well, this is another part of this historical trauma, and how do you address that from a caregiving. So I look forward to that. So I lit a smudge too for the survivors and the ones that passed too. And I have my little tobacco here as well, which I put down to honor all past patients and survivors. So I say miigwech, onjene gashkito chamo dose koje nongom, we doko kakina pamatsajik nongom, mame daje non ya Alkasuwin tuberculosis jinka deg, mame kakina pamatsajik. Amigwachote kakina gagisha danonje mamdege nindekiminan, a shich kakina gujia nibi, a shich ishkude kakimijin chimino pamatsian, chimino Aldapananya kakina, a shichia widokwa kakina, miigwech nasewen kakimijin chimino pamatsian, a shich widokwa kakina dajakusijik Omdege COVID-19 sin cádeg shich we do qua kakina ni chino wendagan of nimishom sanan, ni gopmusnan, a shish ni don't is all shin no go monjin abano chishak, the bashkadag me kamashed in his work. A shish kakina guch ya gakisha dane, mitigo, mishiski, mashkiki, ya kakina guch, a wensisak. Pemiswajik, Pemadigajik, Pemudagajik, a shit we do qua kakina no gum. Mom de gay we wisnajik, the magazajik, kaye, augusajik, kaye, we me god with jik no gum, a shit, we don't go out, chiwana key watch, a shit chiminopomanza watch, can't shish quat nigwe decimin, a shit kana noach, kuch nigwe decimin, shwen mishnon in abigus, miigwach, yeah, miigwach is thank you. In Algonquin, say merci en la langue algonquin, et j'ai dit ça 4 fois, and I say this 4 times, to honor the 4 directions, the 4 seasons, the 4 stages of our lives here. And one of the biggest teachings is that also we're here for future generations and the evolution of also handling sickness too as well. So I honor the knowledge keepers that are presenting today because we have stories too in like my grandfather who went to a sanatorium and sometimes they weren't sure if they would return. So I say miigwech everybody and look forward to the discussion. Miigwech.
Attends, je vais le fermer le son sur ce.
Oh,
Thank you.
somebody has their speaker on.
Thank you very much, Elder Verna, for those words and for really laying the foundation, as I said, to this talk today. We really appreciate you being here, especially with such an important topic. I will now like to welcome our 2 presenters today, Dr. Holly Graham and Tina Campbell. Dr. Holly Graham is a member of the Thunderchild First Nation in Saskatchewan. She's worked as a registered nurse in northern communities and various other healthcare environments over the last 40 years. Currently, Holly is an associate professor in the College of Medicine Department of Psychiatry at the University of Saskatchewan and maintains an active practice as a registered doctoral psychologist. Her research focuses on Indigenous health, mental health, and wellness. Welcome, Dr. Graham. And Tina Campbell is a registered nurse who's lived the majority of her life in the Canadian Arctic. Tina has 14 years of experience working in various roles within TB care, specifically with remote and isolated communities. Currently, Tina is the TB advisor for Northern Intertribal Health Authority that provides services to 33 First Nations communities in Northern Saskatchewan. Welcome, Tina. To both of you, thank you so much for being here today and for sharing your knowledge and experiences. Before turning it over to you, I will let participants know that there will be time following the presentation for some questions and discussion. And Holly and Tina have very graciously offered to contribute a prize in the form of some very cool swag to randomly select a participant that contributes a question or a reflection during the Q&A period. So please feel free to post your questions for Holly and Tina in the Q&A box throughout the session, and we'll visit them toward the end of the session. If you would like to follow the presentation in French, a French PDF version has been posted in the chat. And with that, I will turn it over to Dr. Graham and Tina Campbell.
Thank you. Thank you for the land acknowledgement, and thank you, Elder Werner, for those very supportive words at the beginning of the session. And you're so correct when we look at the history and we think about the next 7 generations in the future. And I think it's why we have to have these conversations. So just a little bit of background. I like to provide a context. My mother and on my mother's side attended residential school, and this is my maternal grandfather with a big heart, and my maternal great-grandparents on my mother's side. So I was born into Indigenous health, and I've worked most of my life and as a registered nurse for 40 years as well. So thank you for the opportunity to come and talk. And I want to talk a little bit about the history. And when we look at the history of colonization, we know that it has been devastating for Indigenous health. And there's a multi-complex kind of approach, or pronged approach that needs to happen. And we can only address a part of that today. So what mostly we're gonna be talking about is how do we improve access? Because that's really, as nurses, our point of where we have that capacity to change some of these health outcomes. So I really want to talk a little bit about the history and a little bit about this new tool, CPR racism. The resources are being put in the chat box, so you have resources for the article, for the postcard, and everything that I'm going to be talking about. I often get the question, why do we have to talk about Indigenous people separate from EDI, equity, diversity, inclusion? And I'd just like to remind people that Indigenous peoples, First Nations, Métis, and Inuit people are the only people in this country who have a unique socio-political history with our government. They're the only groups of people that the federal government, the Canadian government, has deliberately created policy to actually annihilate, and that has resulted in genocide and cultural genocide. So there's no other group of people who come to our country, who are in our country, who have experienced the same policy that has been racist and has created these health disparities that we are continuing to witness today. So I'd like to kind of put that at the forefront and talk a little bit about the impact of this history. So the challenges is many people are not aware of this history, and it's also not unique to Canada. It's happened all over the world where there's colonizations has happened. So it's really important that as healthcare providers, we're aware that this is not unique to Canada, but the certain health disparities that we see are consistent globally. We know Indigenous peoples do not have the same level of health. We look at metabolic, like diabetes, or we look at cardiovascular, and then we look at mental health. Our rates are significantly higher, with suicide, with the Inuit people being as much as 11 times higher than the Canadian population. So we know that there are health disparities, and that's part of the reason why we're doing these talks. So we have to talk about Indigenous health within the context of colonization, because that's really where it's rooted of much of what we see. I wrote the CPR racism guide as a response to call from my colleagues, but mostly it was a response to what happened to Joyce Echaquan. I was curious and actually heartbroken. How could something like that happen in this day and age? You know, nursing is so deeply steeped and entrenched with cultural safety, cultural competence, and we have brought this into healthcare. And, you know, in terms of being so aware of differences, that people see the world differently, they locate themselves differently, different beliefs, different practices. And so this really was the impetus for me to write something. And that is a very sad state. I don't think anybody should ever have to transition into spirit world, having their last few moments in this type of context. When they looked at the coroner's report and inquiry, they did actually acknowledge that systemic racism was actually part of this, and in fact comments, if she had not been Indigenous, chances are that she may still be here with us. There has been significant movement with both CNA, Canadian Nurses Association, and CAUSN, Canadian Association Schools of Nursing, in terms of responding to I would say outcries that have happened across Canada and lobbying, and they have officially apologized for the care that Indigenous peoples have received from many of the graduates in nursing schools, but also for Indigenous nurses who went through the curriculum, who went through the learning systems, who have also faced similar barriers and challenges. So they made some very specific recommendations about more anti-racism training, looking at curriculum, of course, including community, and how do we get more First Nation, Métis, Inuit nurses into healthcare, and looking at ways of accountability. So really there is much more of a awareness and a certainly dedication and a commitment to want to change, you know, experiences of healthcare related to racism. Call 24 is now required for accreditation for all nursing schools in Canada. And what I want to draw your attention is they're asking for anti-racist skills to be developed, to be taught, and as part of competency into nursing. So this really has spurred on education models. It's spurred on anti-racism guidelines, which we have done in Saskatchewan to create this new competency for existing nurses in practice, but also for our upcoming graduates coming into the nursing profession. So this past is important because the past impacts the present. So we have to talk about the past. So I'm going to give a kind of a mini history. And if anyone wants more information, I have a PowerPoint that has a lot more information, goes into depth. Just simply reach out to Charlotte and I will send my PowerPoint to her. It has all the links and then you can actually have access to that. I'd just like to draw attention to those of you who look at trauma and you look at adverse childhood adverse experiences. We look at ACEs. We know that trauma and these types of experiences impact all peoples. And this study was done with white, middle class, college educated individuals who lived in California back in the 90s. And they saw that there was this direct link between these adverse childhood experiences before a person is 18 years old and the development of other conditions from social, emotional to physical, and of course, impacting mental health. So if we were to overlay that, what the experience has been for First Nation, Métis, and Inuit people with residential school and colonial practices, we can start to see why we see some of these health disparities, and particularly when we look at the impact of residential schools. The doctrine of discovery in itself is racist. It gave the authority to explorers to claim land that was not occupied by Christians. So anybody who's attending this today, and if you're not Christian, according to the doctrine of discovery, you would not be human, meaning you would not have rights. So our Canadian law is founded on this. Epidemics was really critical when we look at the demographic collapse of Indigenous peoples. Prior to this, they were 1/5 of the world's population, millions. And when we look at our current demographics, we're about anywhere from 5 to 6% of the Canadian population. And that was within 2 years of contact, the demographic collapse that happened. Of course, the Indian Act was the way that made it so-called legal, and it made it possible for all the marginalization, the residential schools, the Indian Act, the Indian hospitals, those colonial institutions were not optional for our relatives. They had no choice. So there's been this whole history of colonization has resulted in mistrust being a barrier when it comes to access and engaging with healthcare providers. And this really has been earned by healthcare. It's been earned in many of our systems. And so when I look to mitigating and trying to change some of this path, I always look at choice, because to me that's the closest we can get to decolonization, because colonization is the imposition. So it's really about how do we engage with trauma-informed care and choice. If we could just go back to that one slide, that was an accidental request for movement. And when we look at the harm of cutting hair, and we know that there's lots of sacred teachings about when we cut our hair, how it's cut, and what's done with our hair. And we look at that was just one practice that was done in residential schools. We look at that as history, and we look at that, and I think many of us just think like that could never happen again. But it did happen again. It happened last fall here in Saskatchewan at our university hospital, where an elder woke up without his braid. And so this is why I think we really have to re-engage with what is cultural safety, what is cultural competence, what is a therapeutic relationship, and what are our responsibilities as nurses? How do we advocate? How do we fit in there to ensure that this and these types of practices are just no longer happen? COVID was devastating globally for everyone in the world, but again, Indigenous peoples had more to deal with, given the disparities with the social determinants of health, but also the unmarked graves happened. Indian residential school settlements happened during that time. So they had more reopening of past traumas that happened throughout. We talk about Indian hospitals. Tina's going to go more in depth about those. And these were funded at half of our provincial hospitals. So Indigenous peoples have traditionally received much less of the resources when compared to the Canadian population. This also extended to education. The Truth and Reconciliation calls to action 10 years ago really pointed out we need to learn about this history. We need to understand it so we don't repeat it. And it gave us perfect, so to speak, formulas or pathways that we can start integrating First Nation, Métis, and Inuit people into all fabric of Canadian life. And part of the challenge is they're not mandated. They're simply called. So it's really up to us as individuals. It's up to us. How do I participate in this to start mitigating the past? What's my responsibility? As practicing nurses, we have significant responsibility. We have a responsibility to ensure every person who comes into our care is afforded and provided in a safe environment and treated with respect. And that in itself, even if we don't advocate or we don't, push for policy changes, if we're doing that, we're mitigating. So racism really is a structural system where one group of people receive privileged care and opportunities, and another group is actually oppressed. And this creates barriers to health. And it is a form of violence, and it is a barrier towards equitable care. So racism really is critical. We talk about it, we have to name it to tame it. And anti-racism is beyond being not racist. It's actually action, and it's actually naming it, calling it out, and looking at ways to change it. That's what being anti-racist is about. And that's what we really want everyone to be looking at intentional practice. So this really led to this guide, and really it's a concrete visual guide. And many of my colleagues would say, well, how do I teach? How do I teach nursing students? Like what's a process that I can tell them to follow so people feel more comfortable for those who do want to intervene, but they don't know how? And so this really, to me, was the conundrum. And during COVID, of course, I was binging on Netflix. I think many of us were. And I was watching Grey's Anatomy, and little Meredith, everybody who came through the door, pretty much they're giving CPR. And it was a message. This is life-threatening. And so as I was watching one evening, I just thought, that's what it has to be. I have to write a guide, and it has to be CPR racism, to draw attention that my relatives, our relatives, are dying unnecessarily. And so that's where the title came up. And it was really to support a speak up culture, because that's what the In Plain Sight written in 2020 said. We need to support our healthcare providers to actually stand up and to make a difference when we see care that's going sideways, not following evidence-based care. So it really is about looking at this guide and understanding that it's not linear. It's not like you do 1, 2, 3, 4. It's all these things, all these steps. So the first really is getting involved, calling out, how can I help? You target the behavior, not the person. It never goes well to call someone racist, and it's not the time to do it when you're looking at someone's life who may be hanging right now when you're in this interaction. It's plan and practice in advance. You have to decide that this is something you're going to do. Planning and practice is just know what good quality care is, know what the standards of care are, find a mentor, find some support if you need that before you feel comfortable. Our first R is review the chart, speak to the client, assess the client. This is really critical. We can't in a meaningful way get involved in someone's care if we don't actually know what's going on with them. And we may see something that doesn't look appropriate, but I would suggest that we find out, talk to the client, do your own assessment, listen to the lungs. Had other nurse did that with Joyce, there may have been a different outcome. That second R, I think, is probably the most difficult for people to do. That's to review the treatment plan and to respectfully request for rationale. So I wrote a paper, and all these resources are in your chat box. And I say, for example, I reviewed the chart, I've assessed the client, and I'm wondering what is the rationale for the current treatment plan. Or you could say, as a nursing student, please help me understand the evidence for this type of approach. Or simply, what are the goals of this current approach? So I give some ways to ask these questions, to pause what's happening right now, because people are going to have to respond to your questions. And I think that sometimes because the pause, it gives people a moment to reflect. Or you could say, I've assessed the client according to what I'm reading in the chart, and what typical treatment for this is you do ABC, and we're not doing that. Can you help me understand the rationale for this current approach? So it's really about being respectful and asking it kind of from a learner perspective, but be very clear that you know kind of what the treatment is supposed to be. Allyship, it's really important that we keep educating ourselves and our colleagues, and that we learn more about becoming anti-racist. C, check with the client. It's really important you verbalize your position. When people talk about being in the hospital, they say, my nurse, my nurse. It's like a possessive. We are their people. So I think it's really important that you state your position. It's like, check with them and state your position, like, are you okay? I believe you. I'm here if you need something. I will check back in with you. Those types of statements are validating to this person in front of you that you're there for them. Intervene, always intervene. I know when there's groups that it's very difficult, and sometimes with group mentality, that's why with CPR, we always say, you with the green shirt, you call 911, because we know the more people there are, the less likely someone will respond. And speak up to your leadership and talk about your concerns. There are some issues going on in different units and different hospitals. I do lots of professional development within hospital settings, and the stories that nurses tell me are very concerning, and they want to make a difference. So sit down, talk about it, read the articles, and think, what can we do? Nurses rule. If you decide that there's certain policy you want to change, maybe you want to create or use a metric that determines patient priority for surgery, so it's not left up to the physician or someone to randomly decide who's first and who's last. And last, if you're not comfortable, not ready, you need more support. If you just model safe, competent, ethical, compassionate, and trauma-informed care, then you will be mitigating any harm that's happening. So I just invite you to engage and reflect on this. And Tina is going to continue with the presentation and talk more specifically about TB. I want to draw your attention that there is an Indigenous professional practice group in Saskatchewan, and you're going to get some swag from there. Some lucky person is going to win one. And they're beautiful kind of buddy hugs, and you can just tell me what color you want and the size, and I'll order it if I don't have it in. Thank you. Hi.
Thank you for that, Holly, and thank you for the elder for opening this session in a lovely way. We are kind of short on time, so I'll just get right into it. My presentation focuses on the historical treatment of tuberculosis specifically, and the ongoing impacts that we see today. It's broken into 3 parts. I'll talk about the history of TB, talk about the ongoing impacts, and then what we're doing towards reconciliation and healing. Historical TB control practices in Canada, particularly towards Indigenous populations, have fostered significant stigma and discrimination. These practices have led to fear, mistrust of the health system, and a reluctance to seek care. Stigma, rooted in past injustices, creates barriers at both individual and systemic levels, resulting in delayed TB diagnosis, ongoing transmission, poor health outcomes, and lower treatment completion rates. It is widely recognized that as one of the most significant human rights barriers at both individual and systemic levels. Oh, did I say that already? Sorry. It is widely recognized as one of the most significant human rights related obstacles to ending the TB epidemic, impeding access to care and reducing the quality of life for affected individuals. The feelings of shame, guilt, and fear associated with stigma hinder collaborative care efforts, ultimately compromising TB control and prevention strategies. And if you ask any of our frontline nurses working directly with TB, they could all share experiences and challenges they face due to stigma associated with TB. Tuberculosis was introduced to Canada by European settlers in the 1700s and quickly became a major public health concern. So by 1867, TB was the leading cause of death in Canada, prompting organized efforts to isolate those infected in sanatoriums. The spread of TB to First Nations and Métis communities began around 130 years ago, particularly during the construction of the Canadian Pacific Railway and the establishment of the reserve system. Conditions on overcrowded reserves combined with poor nutrition greatly increased the spread of disease. In the 1960s, the introduction of antibiotics offered a more effective treatment for TB, replacing the previous reliance on rest and long-term stays in sanatoriums. So before antibiotics, individuals could spend years in isolation as their only hope of recovery. Unfortunately, many Indigenous peoples who died from TB and other diseases while undergoing medical care were buried in unmarked graves, as Indian Affairs refused to fund the return of their bodies to their home communities, further deepening the historical injustices faced by these populations. The residential school systems in Canada operated from the 17th century until the late 1900s, forcibly removing Indigenous children from their homes to attend institutions designed to assimilate them into European ways of life. These schools were primarily run by Indigenous organizations with funding and administration from the federal government. Indigenous children were subjected to harsh conditions, including physical, emotional, and sexual abuse, neglect, malnutrition, and the suppression of their cultures and languages. Many children died while at these schools, with their burial sites often remaining unmarked and unknown. The Truth and Reconciliation Commission of Canada described the residential school system as a form of cultural genocide, which deeply undermined fundamental aspects of Indigenous cultures, including family structures, traditional knowledge, languages, and connections to the land. At least 150,000 First Nations, Inuit, and Métis children attended these schools over the course of the system's existence. The goal of the system was to erase Indigenous identities through forced assimilation, which led to intergenerational trauma. The last residential school closed in 1996 in Saskatchewan, marking the end of an era that left a profound impact on Indigenous communities. These schools were a key part of broader colonial efforts to suppress Indigenous peoples, histories, cultures, and ways of life, contributing to the ongoing struggles with health, identity, and healing within these communities. Dr. Peter Henderson Bryce, the physician and chief medical officer of the Department of Indian Affairs, investigated the alarming death rates in residential schools, particularly noting that TB was the leading cause of death among students. His findings, especially in southern Alberta, where 28% of residential school children had died, highlighting the devastating effects of poor living conditions, overcrowding, inadequate sanitation, and poor ventilation. This facilitated the spread of TB. In 1907, Dr. Bryce made several recommendations to improve these conditions, including better nutrition, construction of safer buildings, and the presence of TB nurses on site to monitor the health of the students. Despite these urgent recommendations, the federal government chose to ignore them, deeming the cost of implementing such measures unjustifiable. This neglect of Dr. Bryce's findings and recommendations illustrates the systemic disregard for Indigenous children's health and well-being, which is a key factor in the ongoing mistrust between Indigenous communities and the healthcare system. The failure to address the conditions that led to widespread TB transmission in residential schools and the refusal to invest in health of Indigenous children compounded the trauma caused by the school's broader goals of assimilation. The historical negligence contributes to the lingering mistrust of healthcare systems today, as many Indigenous people view medical institutions as extensions of a colonial system that has historically harmed and neglected their communities. The legacy of such disregard for their health continues to impact their relationship with healthcare providers and systems, perpetuating the cycle of mistrust and underutilization of health services. In Canada, Indigenous individuals suspected of having TB were often sent to sanatoriums under the Indian Act. And for children, this was done without parental consent, as their families were frequently hundreds of kilometers away on remote reserves and unaware of procedures. This system allowed children to be removed from their communities and placed in sanatoriums, sometimes directly from residential schools. Medical historians note that this practice was also seen as a financial win-win, as it helped maintain occupancy rates in both residential schools and sanatoriums, where funding was often tied to maintaining quotas of patients. By the 1950s, even though effective therapies were available that would allow TB patients to be treated at home, Indigenous patients were still kept in sanatoriums for extended periods, often years longer than the non-Indigenous patients. This prolonged detention, despite the availability of more effective treatments, contributed to separation of Indigenous families and communities. The combination of forced isolation and the disregard for consent deepened the mistrust between Indigenous peoples and the medical system. This slide shows a picture of my kuka, my grandmother, on the right, outside Fort Capel TB Sanatorium. And on the left is a picture of Fort Capel. So in the 1950s, my kukum was sent to the Fort Capel Sanatorium twice. where both adults and children were forcibly separated and forbidden to interact. During the same period, my young aunt, who was under 10 years old, was sent to the same facility. The stories my Kukumin aunt shared about their time are heartbreaking, filled with accounts of abuse, force feeding, isolation, and medical experimentation. My Kukum also left behind her infant daughter, among other siblings and children that she had, who was just under 1 year old at the time. Over time, this child was told that her mother was likely dead and that no one ever returned from the sanatorium. These painful experiences deeply scarred my family, creating a lasting trauma that continues to affect their relationships with healthcare systems. When talking with my family, there's always speculation as to what exactly my Kukum had experienced. She stated at one point feeling helpless and feeling guilt for being away from her family, and she thought that she would never return home. We often wonder if she was someone who had also undergone some sort of experimental treatment. The act of medical experimentation was carried out without consent, as I had mentioned, and then also done without misunderstanding due to language barriers. It caused irreplaceable harm. The impact of these traumatic experiences, compounded by forced isolation and the loss of trust in the medical system, continues to affect my family's perception of healthcare and TB, creating a deep sense of mistrust that remains today. So the purpose of Indian hospitals in Canada was to address the spread of tuberculosis among Indigenous populations, driven by the fear that these communities would pose a health threat to nearby non-Indigenous populations. These hospitals were not established out of genuine concern for Indigenous health, but rather from deep-seated inequities and prejudices about Indigenous people, viewing them as a perceived threat to public health. The creation of these institutions reflected a broader colonial mindset where the health of Indigenous peoples was secondary to the fear of TB spreading to the non-Indigenous population. These hospital conditions. So in these hospitals, practices such as experimental treatment and painful and disabling surgeries were prevalent, even at a time when general hospitals were switching to less invasive treatments for TB. And although forced hospitalization and physical restraining of patients was not permissible in a general hospital setting, they were considered common practice at Indian hospitals. So again, similar happenings in these institutions as sanatoriums and residential schools. So in 1953, Florence Janae, a young Ojibwe girl from Rolling River First Nation, was sent to a sanatorium in Brandon, Manitoba for suspected tuberculosis. While there, doctors subjected her to painful and unnecessary medical experiments, including binding her to a gurney and administering electric currents to her body, causing her limbs to convulse. Despite having no evidence of tuberculosis, doctors performed an invasive surgery on her thigh, leaving her with permanent scars in a limb. Janae later learned that she had never had tuberculosis and now believes that she was used as a guinea pig in a medical experiment, a sentiment shared by many other survivors at these sanatoriums. Many survivors, like those shared in the CBC article above, recount harrowing experiences of being subjected to invasive procedures without consent, including surgical experiments. So these practices were often carried out under the guise of medical care, but were driven by colonial attitudes and viewed Indigenous peoples as expendable. Survivors also speak of being separated from their families and communities, which led to emotional and psychological scars that have lasted for generations. These stories are just a few among shared through various media outlets. I encourage you to do a quick Google search and you can listen to some of them. So these survivors continue to speak out, shedding light on the ongoing impacts of these experiences. And these accounts not only highlight the historical injustices faced by the Indigenous people, but also just to illustrate the profound mistrust in the healthcare system that persists today. So ongoing impacts to health. The legacy of the Canadian government efforts to colonize Indigenous peoples continues to affect our communities today. Policies like the Indian Act and the residential school system resulted in significant loss of language, traditions, and cultural practices, hindering efforts at cultural revitalization. Indigenous communities often experience higher rates of poverty, unemployment, and lower access to education and healthcare, driven by systemic inequalities. The historical traumas of forced assimilation, family separations, and colonial practices had an enduring psychological and social effects, contributing to ongoing mental health challenges and weakened community cohesion. So some implications today that we see in our communities. Indigenous and isolated communities in Canada face numerous social inequities that significantly contribute to the ongoing spread of TB and other illnesses. Poor housing conditions such as overcrowding and inadequate ventilation, creating environments where infectious diseases like TB can easily spread. Furthermore, food insecurity and malnutrition weaken the immune system, making individuals more vulnerable to TB. Stigma surrounding TB tied to the historical treatment of Indigenous peoples further complicates efforts to address the disease. Healthcare access is also a critical barrier as many First Nations communities are far from medical facilities, and high turnover rates among healthcare workers can delay diagnosis and treatment, worsening the health outcomes of these communities. These inequities are deeply rooted in a broader socio-ecological factors. TB reflects the unmet needs of Indigenous communities, including access to safe housing, nutritious food, clean water, and adequate health care. These basic necessities are often difficult to obtain, contributing to a higher vulnerability to TB and other health issues. The under-resourcing of healthcare services and limited access to timely care further impede TB elimination efforts. The high rates of TB Indigenous populations are tied to colonial policies like forced relocation and disruption of cultural practices, which have left lasting impacts on their health and well-being. These systemic issues are not isolated to Indigenous communities, but are shared by other marginalized groups globally. Underlining the widespread nature of these injustices, addressing these disparities requires improved healthcare access, cultural competence, and ongoing efforts to tackle the root causes of health inequities. So while there are ongoing efforts towards reconciliation progress, many Indigenous people still feel the effects of past injustices in their daily lives. So the purpose of the Truth and Reconciliation Commission report was to document the history and impacts of Canadian residential school systems on Indigenous peoples and provide a platform for survivors to share their stories. The calls to action aim to address the ongoing legacy of residential schools by urging the government, institutions, and society to take specific steps towards reconciliation, justice, and healing for Indigenous communities. So in this report, health has specific calls to actions, and they are 8 to 24, and I have 23 on the slide there, but you can also take a look at the report and understand each call to action. In the Canadian TB Standards, the 8th edition, there's chapter 12, and this focuses on, this is for specifically healthcare providers providing services on Indigenous lands and or working with Indigenous peoples to do tuberculosis related work. So they should educate themselves about the epidemiology of TB in the community, recognizing that the community's historical relationship with TB will contextualize present day TB care. Understand the geography and climate of Indigenous communities, including that many Indigenous communities facing high rates of TB are isolated and not linked by roads or to urban centers, with the result that the healthcare is less accessible and diagnosis and treatment of TB potentially delayed. acknowledge the Indigenous territory that one is occupying, work towards understanding and practice cultural safety by self-reflection on power differentials and respecting cultural differences, including language, and incorporate cultural values to support and promote a safe and inclusive environment. I also want you to recognize the specific social determinants of health affecting distinct Indigenous groups with the aim of delivering quality TB care, closing the health equity gaps between Indigenous and non-Indigenous Canadians. Acknowledge the role of ongoing colonization, personal and systemic racism, and privilege as they relate to health equity in TB care delivery, and take steps to prevent their harmful effects. Promote self-resilience, self-advocacy, and empowerment by respecting the rights of Indigenous peoples as outlined in the Patient's Charter of TB Care and the United Nations Declarations on the Rights of Indigenous Peoples. And understand that each Indigenous group, First Nations, Inuit, and Métis, is historically and culturally distinct and may therefore have unique TB needs. So I always leave this with a slide. We do have a long way to go, and including developing anti-stigma interventions, which would be most impactful and successful if it's driven by collaboration between health system leaders and people with lived experience of stigma, designed based on research evidence, diverse ways of knowing, and experiential knowledge. So in conclusion, eliminating tuberculosis requires a collective effort. Collaboration is key to achieving this goal. So as healthcare providers, it is essential that we not only focus on medical treatments, but also on understanding the cultural, historical, and social context in which people live. The historical mistreatment and stigma surrounding TB have often led to mistrust and resistance to care, making this understanding even more critical. By being compassionate and committing ourselves to learning about the unique ways of life in different communities, we can foster trust and provide the most competent, effective care. This holistic approach will enable us to break down barriers, improve treatment adherence, and ultimately work together towards a TB-free world. Thank you.
Thank you so much to you both, Holly and Tina, for the presentation and discussion. I know these topics are really difficult to talk about, but they're so important to bring forward to each of us, and it's important to talk about the hard issues. So just really appreciate your candidness and vulnerability bringing it forward. The themes that you touched upon with respect to the history of colonization, the very dark history and hard experiences related to TB among Indigenous peoples in Canada, as well as you brought forward some really concrete actions towards anti-racism and some foundational knowledge to be able to provide safe care in communities, and not just TB care, but all nursing care. So I just feel really grateful to have learned from your personal stories. So thank you very much. So with that, I will turn it back to Elder Verna to provide some closing thoughts and to end our session today. Thank you so much.
Great, Charlotte. When I went to another event with the Public Health Agency, and one of the things I brought from this too as well, especially the Inuit in the north, they were talking about needing even the availability of X-ray machines. And again, with First Nations across Canada, it used to be like 67% of communities are in rural, remote locations. But then again, as well, TB was the second most infectious killer after COVID. So again, this needs to be still on the radar, and it's still a world health issue. So I think awareness is so important, because they used to also once call this the Indian disease, but it's also with the living conditions. And I like Holly and Tina's points in highlighting that too, because it's all interconnected, as they say, like the web of life and the spider weaving the web of life, and everything is interconnected. And that's why this ongoing increase in improving the living conditions is so important. So I say miigwech kakina onje non gomche kashkito chamawa se onje ya tuberculosis in ka de gakazuin we do ka kakina pamatsik chiminoya chiminopamatsa wajena because a shit kakina dajio damta waj momwe akazuin shwen mishnonina because miigwech. I just say thank you for allowing us to come and have a meeting today. And please help all the people that are working in this field to help the people that are experiencing this sickness. And please help us as we move further with this issue. And I thank everybody and also your dedication to everyone online too, because frontline workers are very important, but also too as well, they would say, Ayongwams, and don't forget to look after yourselves too. Miigwech, everybody. Thank you, Charlotte.
Thank you. Thank you, everybody. Have a wonderful afternoon.